So, stage one hypertension in young adults is such a clinical challenge, and that's because you're really sort of trying to balance their long-term or lifetime risk. And you can't really rely on those short-term 10-year calculators because, as we know, the thing that's weighted the most heaviest in those calculators is often age. So, that short-term risk calculates relatively low. But we also know that having hypertension earlier in life makes it not just a more aggressive phenotype of hypertension, but it also puts a target sign on you earlier that you're going to go on to potentially develop more vascular disease later in life. So you want to be aggressive, but at the same time, you want to be too aggressive because you don't want to medicalize them. So I use sort of multiple different factors to decide when to think about pharmacotherapy. But the first thing I do is just to make sure that it's a real reading. So I give them a home blood pressure cuff and make sure that they're still having hypertension at home. It's not just the white coat hypertension, which I would be less likely to treat in a younger person. So once I've established that it's persistent stage one hypertension, then I really look for secondary causes because in a young person, secondary causes can be a huge driver. Thyroid disease, renal disease, hyperaldo. You could have excess cortisol. You could have sleep apnea, too much alcohol. That's often a common cause in young people of hypertension as well. So I spend a little longer talking about lifestyle measures, sodium intake, decreasing alcohol, being more active, making sure, that they're maintaining their weight. And then if there's any signs of end organ damage, whether that's LVH, albuminuria, they already have chronic kidney disease, or they're a high risk phenotype patient because they're a smoker or for whatever other reason, strong family history or what have you, then I'm basically pushed towards pharmacotherapy. And that's when I think about starting it. It's really interesting. If you look at the long-term data, there's a study that looked at the 19-year risk in patients that have early onset hypertension or hypertension before the age of 40, and they essentially have a 1.7-fold higher vascular risk over the course of their lifetime. And really what we're calling it is area under the curve or cumulative risk exposure. So they start getting exposed to this vascular risk factor of hypertension much earlier in life. And so of course their exposure to this risk factor is higher, which can cause more accelerated vascular disease as manifest by that statistic. It can cause more aggressive disease when it does manifest. But what we also see in these younger patients are higher markers as well of other types of subclinical risk factors as well. So we see more hsCRP elevations or more inflammation. We can see earlier onset of other comorbidities as well, such as chronic kidney disease and diabetes, because remember, blood pressure influences all the other organs. So when you start to have a high blood pressure earlier in life and that cumulative exposure is a lot higher, you can start to see more onset of dementia or vascular disease. You can see earlier onset of atherosclerosis. And like I mentioned, many of the other traditional ASCVD risk factors as well. So they also get accelerated plaque deposition. So in these young patients, it's really important not to just look at that 10-year risk. So what I do in my young patients with hypertension, I put them in the calculator, but I really look at that lifetime risk because I think that's what pushes me to start to think about therapy early. I look for markers like LVH, albuminuria, chronic kidney disease, all of those markers that tell me that the organs are starting to misbehave. And I think that's what I use as my metrics. Now, I'm hopeful in the future we'll have more sophisticated metrics where we can start to say, well, why is it that African Americans get more earlier onset hypertension? Or why is it that certain types of earlier onset hypertension, such as the one that women get during pregnancy, manifest differently than other types of earlier onset hypertension. But for now, I'm really relying on that lifetime risk scoring system, markers of end organ damage, as well as kind of the patient's family history and background to try to decide how to stratify their risk. In younger patients, it's such a challenge because you're talking about taking somebody under the age of 40, putting them on a medication for the rest of their life. So that's the vascular argument. That's the medical argument to protect their arteries. But on the other side of it is the psychological burden of taking a medicine for the rest of your life, starting in your 30s or what have you. And then also potentially the risk of over medicalizing people, right? Because we know that we don't have a lot of guidance when it comes to early onset hypertension. So I think I have an approach that that's multifaceted. The first, as I've already said, is you really, really, really have to spend a little extra time on lifestyle in these patients because you have to teach them that they have control as well. Because getting a diagnosis of a chronic illness like hypertension below the age of 40 can be a life-changing diagnosis. And hypertension is referred to as the silent killer and what have you. And it can be really, really scary for these young patients. So educating them about their diagnosis, talking about the reversibility of the diagnosis early in the trajectory of the disease. Because when their blood pressure first starts to go up, you don't know yet what that trajectory of that blood pressure elevation is going to look like. But we do know that early in the disease, blood pressure tends to be more reversible, particularly in younger patients because their vasculature has more elasticity as well. So I really try to empower my patients by, again, emphasizing the DASH diet, keeping that sodium below 1,500 milligrams, very little alcohol, if none whatsoever, if they can put up with that, making sure that their sleep apnea is treated, their weight is good, they're being active and exercising. And then on top of that, I make it so that it's not like a chronic illness, a dagger over their head, but it's more something that we just need to tune up a little bit. And that, I think, is the best combination to really improve long-term adherence. Because the last thing you want to do is pound somebody with a ton of medications that's going to cause a lot of side effects or have them burn out on those medications early. So you really want to try to teach them that controlling the blood pressure is about having control of this diagnosis of hypertension. It's about making sure their body and their organs are aging well. And it's not necessarily a dagger hanging over their head so early in life. So that's kind of been my approach to really try to help people to be compliant for the long term, because really this is the long game. I also start usually with monotherapy. So normally our mantra in blood pressure has been combination therapy, right? Use multiple medicines and hit it hard. But in my younger patients, I kind of have them get into the swimming pool one toe at a time, so to speak. I don't have them cannonball in. So I'm really easing them in with very little doses of medicines and a really graduated approach so that they don't feel either overwhelmed by the pill burden or they don't feel overwhelmed by any potential side effects. What I really love about treating young adults is that they're so tech savvy. So it's really helpful for me because I rely heavily on home blood pressure readings. Now, this is a little different from wearables because wearables, I think, still have some ways to go. There's some trends and stuff you can pick up in wearables, but I don't rely on wearables as a diagnostic tool. But ambulatory blood pressure monitoring and home blood pressure readings, I think, are critical in my young patients. And that goes back to something I said earlier, which is the first and most important thing is to actually identify the diagnosis of hypertension accurately, ensuring that it's not just white coat hypertension, but they're actually elevated in the ambulatory setting as well. The other thing I really like about home blood pressure monitoring, in addition to the fact that young patients can tend to do it pretty easily and keep diaries and logs and stuff for me, is that I can look for diurnal variations, which is also very helpful when it comes to blood pressure and lifestyle as well. So often what I have my patients do is check a morning and an evening blood pressure. And as we know, we expect to see a 10 to 15% drop in our blood pressure right before we go to bed, right? That's kind of the normal pattern that it should be. And you have some people who are exaggerated dippers, and that's a sign of disease. And you have some people who are blunted dippers, and you have some people who are actually paradoxically increase their blood pressure before bedtime. And these are all signs of adverse prognostic markers when it comes to hypertension. So I use these technologies to not just make sure that they have hypertension, but to figure out kind of what the trajectory and the phenotype of their hypertension is, so to speak. So I can really sort of try to understand and incorporate, okay, well, it seems like you're going to bed really late or at a different time every night. So your blood pressure is not dropping at bedtime like it's supposed to drop. Or it seems like right after you take your morning medicines, your blood pressure really plummets. So maybe you want to split the medicine and take it twice a day or what have you. So I love the idea of using the ambulatory blood pressure cuffs. I'm not crazy about the wearables as a diagnostic tool, like I said, because they haven't been validated clinically. Often they're cuffs, which I don't find as accurate as the arm monitors. And sometimes they're those stick-on patches that are looking at photoplethysmography as a way to assess blood pressure. That still needs a little bit of work. But if somebody wants to wear it just to look at blood pressure trends and then validate with the cuff on the arm, I'm okay with that. I also like to teach my patients how to accurately check blood pressure, which I think is something that's not emphasized enough. You got to sit quietly, back supported, feet flat on the ground, empty bladder, not talking, not laughing. Check it in twice in the same arm. If it's more than 5 points difference, then you want to check it in the other arm as well. You don't want to check it after exercise. You don't want to check it after caffeine. You don't want to check it when you're watching the news and getting stressed about what the president is saying or what have you. So you want to make sure you're doing it the right way every time in order to get good reading. So I like this technology for my young patients. I'm really excited about what the future holds and how the guidelines are going to shift for younger patients. I do believe that they're going to start to become more aggressive than they've already become. But one of the reasons that I don't think we have seen the guidelines really put their nickel down on young patients with stage 1 hypertension is because a lot of the data is observational, right? It's epidemiologic and it's observational, and we're lowering the blood pressure, but are we actually reducing vascular outcomes? So really what I would love to see if I had a genie in a bottle is a randomized controlled trial of young patients, probably under the age of 50, even under 40 would be amazing, but under 50 I would take, randomized to either intensive lifestyle modification or early pharmacotherapy, and then having some sort of a follow-up looking at major adverse cardiovascular events and hard clinical outcomes to see if we're actually making a difference, to also see if the adverse effect profile, again, for a younger patient, you're talking about a lifetime of being on these medications, is tolerable, and making sure that there's no emerging safety signals in our younger people. Now, we've been talking mostly about patients under the age of 40. So certainly for women of childbearing age, being on blood pressure medicine can certainly be a bigger impact because it can affect their ability to get pregnant. And we have to choose certain medications if you're thinking about getting pregnant. So I'm hoping some randomized data in this population will emerge to really help guide us. I'm hoping that we're not just looking at subclinical markers of disease, but we're actually starting to look at some of those hard outcomes. But it would be nice to also look at some of these biomarkers in these younger patients and see if we're changing the trajectory of the biomarkers by starting earlier pharmacotherapy. I'm hoping the guidelines in the future also start to incorporate things like polygenic risk scores, which I think are really important because, again, we don't quite understand why some people get hypertension so early and so aggressively and others don't. They wait until their 50s or 60s for their arteries to stiffen. So having some sense of family history polygenics, because that tells us how aggressive the phenotype of blood pressure is, having randomized trial evidence, and then also showing that we're actually modifying heart outcomes. I think these are all things that I would want to see in the guidelines to help guide me in the future. Certainly, I think where the guidelines are headed are the normal blood pressure for young people is going to start to be less than 120. And that's another cultural thing we have to really start to put out there because most of us think of normal as less than 130. And I really want us to remember that 120 to 130 is already considered elevated blood pressure, and that's patient education. So lots of excitement coming down the line in the future in terms of research and treating young patients, but it's always such a challenge. But it's one of those conversations I really enjoy as a clinician because it gives me the opportunity to educate. It gives me the opportunity to really have a shared decision making to assess whether my patient's motivated for lifestyle changes or if there's somebody who's going to do better with pharmacotherapy, and to use so many different things to really think about how to reduce their risk.